All right, so welcome to our last seminar, the Disability Health Research Seminar Series. We are honored and lucky to be speaking with Dr. Rupa Valdez today, an associate professor at the University of Virginia, and I will read her bio in just a minute. My name is Franz Castro. I am a research associate at the Disability Health Research Center at Johns Hopkins, and it is my pleasure to welcome you all here today. My visual description is I'm a Latino man with black hair, in my 30s, wearing a black suit, sitting in an office in Baltimore. My pronouns are he, him, and I am thrilled for this conversation today and for you all joining us. I first want you to know that we have card captioning services available. You can find the link in the chat, and we also have ASL interpreters joining us. So thanks to the interpreters and captioners are helping us today. So we're going to be talking about disparities for people with disabilities and the role that structural ableism plays in exacerbating these disparities. In terms of logistics, after a moderated discussion between Dr. Valdez and myself, there will be a Q&A session with the audience. Please place your questions into the Q&A, and your messages will be sent to the panelist and the moderator, and then will be read out loud on your behalf. Please remember that we have ASL and closed captioning card services, which are provided through Zoom and the link that I just mentioned. And for your awareness, this session is being recorded. If you have any technical difficulties during the session, particularly in terms of access needs, please contact Mindy at epits or at jhmi.edu. Next slide. We would like to begin today with a land acknowledgement. We recognize the enduring presence of more than 7,000 indigenous peoples in Baltimore City, including the Piscataway, Lumbee, and Eastern Band of Cherokee community members. Next slide. For those joining us for the first time, this series is linked to a course at the Johns Hopkins Bloomberg School of Public Health in partnership with the Disability Health Research Center, directed by Dr. Bonnie Sweeter. Next slide. Oh, that was the last one. Yeah. So if you want to learn more about our work, you can do so by going to our website, disabilityhealth.jhu.edu. And you can also check out our podcast included and our social media channels where we will be posting about this session. And with that, I will introduce our speaker for today, Dr. Rupa Valdez. Dr. Rupa Valdez is an associate professor at the University of Virginia with joint appointments in the School of Engineering and Applied Sciences and in the School of Medicine. She is also a core faculty member of Global Studies and the Disability Studies Initiative. Dr. Valdez merges the disciplines of human factors engineering, health informatics, and cultural anthropology to understand and support the ways in which people manage health at home and in their community. Her research and teaching focuses on health disparity populations, including communities of color, rural communities, and the disability community. Her work draws heavily on community engagement and has been supported by the NIH, the AHRQ, the NSF, and the USDA, among other agencies. She has testified before Congress on the topic of health equity for the disability community and received the Jack A. Kraft Innovator Award from the Human Factors and Ergonomics Society for her pioneering work in creating and developing the subdiscipline of patient ergonomics. Among other appointments, she serves on the board of directors for the American Association of People with Disabilities, on the CORE's Patient Engagement Advisory Panel, and also as a member of the National Committee for Quality Assurance's Health Equity Expert Work. She also serves as an associate editor for Ergonomics, the journal of the American Medical Informatics Association, and Human Factors in Healthcare, She's also the founder and president of Blue Trunk Foundation, a nonprofit dedicated to making it easier for people with disabilities, age-related and chronic health conditions to travel. Dr. Valdez herself lives with multiple chronic health conditions and disabilities, which have and continue to influence her research, teaching, and advocacy. She has been quoted in publications ranging from Politico to Think Vote. And it is my honor and privilege to be welcoming Dr. Valdez to this conversation. I'm really thrilled to be having this discussion. Dr. Valdez, we're really grateful for your time and for joining us today. And before we jump into the questions, I'll let you introduce yourself and give a visual description.
Hey, thank you. It's a pleasure to be here. Thank you for having me. So Rupa Valdez, my pronouns are she, her. And as a visual description, I am a South Asian woman. I was going to say early 40s, but I just had a birthday, so I think I have to say mid 40s now. I'm wearing a black shirt and I have curly black hair that's in a bun right now, and I'm sitting on a dark blue couch. As noted, I live myself with multiple chronic health conditions and disabilities. I am a wheelchair user for longer distances or when my chronic condition flares up. And several years ago, I had a concussion that left me with some vision-related disabilities and a disability that means that when I look at screens for any kind of lengthy period of time, triggers migraines for me. So for that reason, I have my camera off today. And I sometimes like to joke when I do virtual talks that you can think of this more as a podcast. And hopefully that will still work for all of us. So maybe we can jump into the questions then.
Yeah, thank you so much, Dr. Valdez. So yeah, I'm going to go ahead and start with the first question. Just a quick reminder to the audience, if any questions come up as we go along, please type them into the Q&A, and we'll get to those at the end of the session. So, Dr. Valdez, I believe that a good way to start off this conversation is to begin with an overview of your work and the research you have done. Can you describe your research and in particular its focus on health disparities?
Sure. So as you mentioned, Dr. Castro, my work is focused on multiple health disparity populations, and I worked closely with multiple communities. And so I think of my work as broadly focused on health disparities and a lot of community engagement work. That work is focused on communities of color, both here in Charlottesville, where I'm located, across the country, but also in other countries. Also a lot of focus, of course, on the disability community, which is a lot of what we'll be talking about today, and rural communities. And as we know, there's a lot of intersections between those communities and other health disparity populations as well. And so sometimes I think of my work as taking increasingly a purposefully intersectional approach. In terms of my research, more broadly speaking, you mentioned in my introduction, and maybe I'll just reiterate that I sometimes think of my background as pretty eclectic. So I'm trained, my PhD is actually in industrial and systems engineering. And I think sometimes that's kind of hard for people to wrap their heads around. Why do I do the work that I do if I'm trained as an engineer? And so what I like to say is I started out in this space that is considered industrial and systems engineering, but a lot about that, the kind of core idea behind that work is how do we create systems that align with what humans need? So if you start from that point of thinking, then I think a lot of my work makes much more sense in that framework. I also like to say that in graduate school, and actually starting in undergrad and in graduate school, I like to say I wandered off of engineering campus and spent a lot of time with cultural anthropologists. Since as engineers, we talk a lot about designing and creating systems and thinking about redesigning systems to focus on the needs of people, but we don't get a lot of training about how to actually engage with people in their communities. So that's what I was trying to learn in my training as an anthropologist. And then as time has gone on, that work has increasingly moved towards models that are deeply community engaged. I think the other part I would give kind of as an overview of my work as I think about my early work as really focused on digital health, and started at a time when we were talking about bringing computers into people's homes and how do we create systems that people who are trying to manage different chronic health conditions can use to connect with others who are living with the same conditions, for example. How can we build community around that? And over time, what I was trying to do in my work at this intersection of engineering and anthropology and community engagement was to say, what do people's everyday lives look like? What can we learn about their communities, about their social environments, about the other organizations they're embedded within? And how can we create technology that's responsive to all of that? So we're not trying to imagine what somebody needs, but really trying to understand the full aspects of all the aspects of their everyday lives and accounting for that in how we're designing technology. And so I think about that as trying to create technology that was responsive to broader systems. But of course, you know, the more you do that work as you see all of the problems in those systems, and the more you do community engaged work, the more I got the pushback. Well, you know, we can create this technology that is addressing this, but it's really the system itself that we need to shift and change. So I would say over time, my work increasingly has that focus: is what is the community I'm working with pointing to as the part of the system that needs to be changed? And then how can I collaborate, support those changes that need to happen? And how can the research questions that come from the community be the ones I address, as opposed to the ones that, you know, I might be able to think of in ways that are less engaged.
Yeah, thank you for your answer. It is tremendously impactful that you highlight the importance of community engagement and that you elevate health disparities or disparities in general through the lens of intersectionality, because certainly disparities compound for individuals belonging to multiple minority populations. So having said that, your answer is a perfect introduction for our next point, which is structural ableism. You have recently written about structural ableism in the New England Journal of Medicine. Can you give the audience an overview of what structural ableism is and its relevance to public health and research?
Yeah, so let me start out just by saying that we can think of, you know, at the kind of broadest level, think about structural ableism as the structural form, or a structural form of oppression experienced by the disability community. So at the highest level, that's how I would define it. There's a definition that we quoted in the New England Journal of Medicine article that I'm going to read, and it has a lot of different components. So I'm going to read through the definition, and then I'm going to try to highlight a few parts of that, because it can be a lot to keep in, right? And kind of keep in mind all at the same time. So this definition is that structural ableism is a complex system of hierarchical and discriminatory processes, policies, and institutions that privilege and prefer able-bodied people, fail to represent or meaningfully include disabled persons' voices, and are grounded in a network of ableist beliefs and practices that maintain and reproduce unequal outcomes for disabled people and benefit able-bodied people. So I want to highlight this idea of it being a complex system. So not focusing only on bias against or devaluing of people with disabilities, although that's certainly a part of it, but really trying to think about all the different, right? I'm trained as a systems engineer, so this is, you know, what resonates is that we're talking about a complex system, and that the system includes these processes, it includes policies, it includes institutions. And then this part about engagement, Dr. Castro, that you brought up too, is embedded in here, this idea of failing to represent or meaningfully include disabled persons' voices. And then the outcome. So what happens, right, as a result of structural ableism is actually embedded in some ways in that definition. And that is these beliefs and practices that maintain and reproduce unequal outcomes. So in this context, we might be talking about unequal health outcomes, but broadly speaking, talking about unequal outcomes across many different domains. So I'm going to start with that kind of as the broad definition. And then the second part of your question was, you know, giving this overview of what structural ableism is and its relevance to public health research. So again, if I take a starting point as this idea of a complex system, and within public health, we talk increasingly about social determinants of health. And that ties very clearly to this idea of processes, policies, institutions. And in this dialogue of the ways that social determinants of health shape health outcomes, if we look at, what do we consider to be social determinants of health across so many different domains, so education, employment, healthcare, transportation, information systems, communication, housing, food security, technology use. I can name so many, but these are all places where we see exactly this part of the definition, this right grounding in ableist beliefs and practices, and that across these domains of social determinants of health, we see this production of unequal outcomes for disabled people. So I would say that there's a very clear tie-in to the conversations we have in public health around social determinants of health, and the way that ties into how structural ableism manifests across all of these social determinants of health.
Absolutely. Thank you for your fantastic answer. Structural ableism then involves a series of systems and processes, and the outcomes manifest across different domains, such as housing, transportation, healthcare, etc. So having said that, since many members of the audience are researchers or do work with population health estimates, could you please tell us more about how structural ableism can be measured?
Yeah, so this question about how would we measure structural ableism, how would we conceptualize it, I would say it's still it's kind of an ongoing space of research and inquiry. So starting with the idea that what is structural ableism in the context? So the definition I read is from the education literature. How has it been talked about in the health sciences literature? And so I will say that I did this search a few months ago, looking at PubMed and putting the term structural ableism into PubMed, and 5 articles appeared. So it just gives you a sense of how little we've really unpacked this concept within the health sciences, how little has been written about it. And so really a lack of clarity around the construct itself in terms of what is structural ableism, in terms of conceptualization that we can then operationalize into measurement. So I'd say that our first step, in moving forward is the need to really understand the dimensions or domains of structural ableism. And there is some space here, right? There's been work done in other forms, measuring other forms of structural oppression that we can learn from, and we can, I think pretty reasonably emphasize that those domains would also be represented in an operationalization of structural ableism. So thinking about domains such as some of the ones I mentioned earlier, like housing and education and employment and healthcare. We might also consider things like political participation or immigration status, perceived oppression by different social institutions. So there are domains that have shown up in other measures of structural oppression that would be relevant here. I think it's important to think too about other domains that we would reasonably want to imagine including. So things relate to the built environment, to technology, to our communication systems, that would be particularly relevant for a measure of structural ableism. So in some ways, my answer to this broader question of how do we conceptualize it is that there's still work that needs to be done to do that in a systematic way, but that we have some thoughts about what directions that would need to go. And then when we talk about measuring structural ableism, part of what we put forward in the New England Journal of Medicine article was talking about the different levels at which we may want to measure structural ableism, or how it would be important to measure it. So one is at this individual level, and this is based on individuals' personal experiences. And here again, I'm going to pull from some of the literature on other forms of measuring other forms of structural oppression. And if you'll bear with me, I'm going to read an example of a question that was used to measure structural racism that one could imagine could be adapted for use in measuring structural ableism. So this question is, have you ever been treated unfairly, 1, on the job, such as hiring, promotion, or firing? 2, in housing, such as renting, buying, and mortgage. And 3, by the police, stopped, searched, and threatened because of your race. And here again, you could imagine adapting questions like this in the context of disability. So that would be one way to think about measuring structural ableism, is experiences that the individual has had with different structures that are embedded with ableism. Another level would be thinking about measures at a community level. So here we could think about things like the ratio of unemployment rate by disability status. So you're looking here at differences in those who are disabled and non-disabled in terms of the unemployment rate, or differences, for example, in whether people who are disabled or who are not disabled have graduated with a high school degree. So we're looking at a particular geographic area and trying to understand differences for disabled people. Another way to think about this is to, if you want to conceptualize this in the context of a built environment, something like curb cuts, right? What percentage of curbs have curb cuts in a particular geographic region? So I will reiterate, I would say we are still in very early days, and we're hoping to do this type of work really in a systematic way, combining perspectives, both current perspectives and narratives, to try to understand what are the dimensions of structural ableism, looking at historical documents, whether that is oral histories or documentaries or policies, to understand those different dimensions. And then there's the work then of translating that into different types of individual and community level measures that we can then seek to validate.
Thank you so much. A great answer to a very difficult question. And as you pointed out, in order to conceptualize structural ableism, we need to think where these inequities and disparities occur in terms of domains. Also disentangle disparities at the individual versus the population level. And I loved what you mentioned about relying on similar metrics, efforts, or lessons learned from indices produced to measure discrimination against other populations facing disparities as well. So since this series is focused on health equity, can you please talk about the relationship between structural ableism and health equity?
Yeah, that's a great question. And I would say that this is something we are still on a journey to understanding, this link, right? So this link between structural ableism and health outcomes, right? If we don't have measures, it's then hard to talk about exactly what this link is, when the conceptualization still needs to be done and the measures still need to be created. And in some ways, back into then the rationale for why it's so important to create measures of structural ableism, both in terms of providing with that clear definition and operationalization of that definition, both at this individual and community level. But then this then allows us, having this measure allows us to understand the pathways through which structural ableism acts to create these health inequities that we're talking about, and then allows us to then, based on that knowledge, create interventions to address structural ableism, to allocate resources. So all of this is why the measurement is so essential and so needed. I would also say, we're talking about this relationship between structural ableism and health equity. The other really important part of this to me that we both mentioned earlier is understanding then how structural ableism interacts with other forms of structural oppression to then produce health inequities. So to me, this is the other dimension of why this type of measurement is so important, because it allows us to then better understand and measure and quantify health inequities based on these intersectional experiences that people have.
Absolutely. Not only is it important to conceptualize, to measure, and to understand how structural ableism interacts with other forms of structural oppression, as you mentioned, but it is also important to connect those metrics or those concepts to specific actions to advance health equity, as you pointed out. No, thank you for your insightful answer. So moving on, to gain a deeper understanding of structural ableism, it is important to examine existing population level statistics that really speak to disparities in health and participation in society. So could you discuss previous research or statistics that could better inform our understanding of structural ableism?
There's so much to unpack here, and so let me do some, and I'm hoping that some earlier speakers in the series have done this as well, because of course there's a lot of things that one could cover to answer this question. But maybe I'll start out by talking about disparities in social determinants of health, since that's partly where I started in talking about the relationship between structural ableism and why this is so important to consider within conversations about public health. So if we look across domains, right, or social determinants of health, like the criminal justice system or education or employment, transportation, food security, right, we see disparities all the way through. So I'm happy to read some of those statistics. So we can talk about nearly 2 in 5 imprisoned individuals having at least one disability. And because we talked about intersectionality earlier, I will also point out that we know that this intersectional experience matters. So for example, we know that Black disabled people are at even a higher risk of arrest. So by age 28, it's 55% compared to white disabled people, which is 40%. That's one example, right, as related to criminal justice. We can talk about disparities in employment, with 17.8% of adults with disabilities being employed compared to 63.6% of adults without disabilities. If we're talking about in the context of healthcare, the statistic is that 34% of people with disabilities have inadequate transportation to healthcare compared to 16% of adults without disabilities. And for food security, people with disabilities are 5 times as likely as those without disabilities to be beneficiaries. So that gives you, right, some of those population level statistics in the context of social determinants of health. If we're talking about, right, we can talk about these in terms of outcomes, right? Part of that structural ableism definition focused on outcomes. And so we know that, right, differential rates of a wide range of health conditions related to mental health, related to chronic health conditions like obesity and smoking and heart disease and diabetes. But we also know, in terms of what we might consider, at least as an engineer, as process level measures, there's disparities there too. So in terms of the number of people with disabilities who did not have a routine checkup in the past year, differentials in the number or the proportion of people with disabilities who had an unmet healthcare need, and those who indicate not having a usual healthcare provider. So a lot of, right, in terms of health outcomes, but also in terms of what we might consider process level outcomes in terms of receiving adequate care. And then we can move on and again to part of, again, the definitions around attitudinal barriers. So if we think about educational and attitudinal barriers, there's a whole list there as well. And I'm sure you've talked about some of these in earlier in the series, but I'm happy to reiterate a few of these. But from Lisa Iazzoni's work, that only 41% of US physicians report that they were very confident about their ability to provide the same quality of care to people with disabilities, and only 57% of physicians strongly agreeing that they welcome people with disabilities into their practices. And so, there's a whole list, of course, there as well. And maybe I'll just end this by saying that there is, a similar, long list of physical barriers that disabled people experience in seeking healthcare. I think the one that has always stood out to me is the statistic of over 75% of individuals with disabilities reporting that they experience barriers that impede them from using healthcare and wellness services. Just a large majority of people. And the other one that always has stood out to me is that 36% of clinical restrooms do not meet ADA requirements. So I think we can go on. There's just so many examples across social determinants of health, across the physical space, across attitudinal approaches to thinking about disability, and of course health outcomes as well.
Thank you so much for sharing this estimate with the audience. So let's now talk about how we can connect structural ableism or the knowledge that these disparities exist with actions. Of course, to address structural ableism in healthcare settings, for example, we need to think about strategies to increase accessibility. So in your opinion, what are important advances and challenges in increasing accessibility in the provision of healthcare services? And yeah, it certainly connects to an important part of the research you have done in the past.
Yeah, that's a good question. And so your previous question was really at this population level, and I'm going to answer some of this drawing on some of the experiences I've had here at the University of Virginia, and more to be able to do a little bit of storytelling instead of just statistics. So I think of this, your question about what are some of the advances and challenges, and of course they're so intimately related. And to me, one of the huge challenges has always been awareness and then post-awareness of the time it takes to build up to buy-in and action. So as an example, I will say here at UVA, at the beginning of the pandemic, there was a task force where several of us were called in the School of Medicine and in the health system to help think through how we focus on health disparities in our response. And as a part of that, when we got to the point of thinking about vaccination, and I was asked to join, not specifically related to my work focused on the disability community. And to be honest, at that point in time, I'm not sure how many people in the broader health system leadership knew I did work in this space, but rather because some of the work I do very closely with our public housing community here in Charlottesville and in some other groups across that locally. And so given that, when we were having this conversation, when I brought up the needs of the disability community, then I brought up that actually the way we've designed our vaccination clinics are unlikely to be accessible to everyone. I would say that my colleagues on that call are all people I deeply admire, who do incredible work in lots of different communities. It's why we were all called in to do this work together. And at the same time, they had not considered the disability community either as a health disparity population or, a group within our community that we would need to do particular outreach to and think through how we were going to make sure we weren't contributing to growing disparities. And then, so to me, this was the awareness part. And then the other part of this was, how do we operationalize this? And I've done a lot of work locally with community organizations in the disability community. And so it was a lot of coalition, building that we had done before. And so because we had that structure set up, we were able to say, okay, let's reach out to all of our community partners. What would an accessible process look like for reaching out to the community, making sure that they had the types of clinics they needed, that they had the accommodations they needed? How are we going to reach out to people who might not hear through kind of our PSAs or anything else that this was happening? But there was buy-in and a willingness to learn, and it happened. And that has led here to basically a committee within the health system that's focused on access and accessibility. It's led so that I chair, and that involves people both within the health system, but actually across the university who do work in disability studies and in other spaces. And slowly over time, there's been the buy-in, the education, the conversations, all the things it takes to, over time, right, create change. And so now we're at a point where we had asked, there's a lot of different types of things that are required for people who are, trainings, of course, right, within the health system. How do we make sure that they're part of that curriculum is focused on the needs of the disability community? Some of the same topics that we're just talking about, that, what is structural ableism? What are the needs of the disability community? What are the disparities our community faces, for example? What are specific actions that right, as somebody who works in the health system can take to help dismantle it. All of those, right, are part of a training that was just recently, approved to move forward to production. We've done interviews with people in our community across, and those will all get integrated into this training. So I do think, right, some of that, and there's a lot of other things we want to do over time. So I would say that some of the, it's the challenges and advances are intimately related. And so some of it is just, of course, so many of those of us in the health sciences, the training we get around disability is, of course, rooted in a medical model. So it's presenting alternative, better ways of thinking about the needs of the disability community, focusing on the structures, focusing on things that we can change structurally, getting that buy-in, and then moving towards, right, negotiating what implementation looks like, which I will say from my experience has been a really constructive, if slow, process. So I would say that's some of, kind of how I think about locally, how that story has unfolded. I will also say that I would say we've been, the work of the community engagement here has been really valued. And that part has been an essential part of creating those advances. So anything that we're doing in terms of what does this education look like, we're thinking about creating, as there's new builds here at UVA, right? What could it potentially look like to create? What would a gold standard look like? So not just best practices, which still, right, aren't fully accessible, but if we involve the community, what would that ideally look like? And, how can we move that idea forward into implementation? So that's how locally, and then I think, right, you can see some of this unfolding, of course, in much broader conversations nationally. So, right, an important advance has certainly been the designation by NIH as the disability community as a health disparity population. That makes buy-in much easier for those who are tied to thinking about health disparity populations based on, these definitions by those who hold power, right, to create those definitions. And I would also say seeing groups like the AAMC having educational sessions I've been fortunate enough to be involved with that are, again, trying to raise awareness, both in terms of what does it mean to serve our disability community, but also having conversations about what does it mean to have a career in the health sciences as a disabled researcher, as a disabled clinician, and trying to advance that because, of course, it matters who's at the table for these changes to happen.
Absolutely. No, thank you so much for sharing those experiences and stories and perspectives. So this great conversation really helps us reflect on the fact that not only is data out there highlighting these disparities, but also we have what I would say is the most important piece of information, which is the experience and the expertise of the disability community when it comes to understanding and disentangling disparities. So this is a perfect opportunity to continue talking a little bit more about community engagement. Can you talk more about your work and perspectives on engaging the disability community in the overarching effort of dismantling ableism and in research?
Yeah, so a few years ago, I wrote with bunch of other people, a paper for the Journal of the American Medical Informatics Association. And that paper was trying to draw lessons learned from our experiences doing this type of work in the digital health space, but across many different projects and in terms of the different advocacy and activism that many of us are involved with. And all of those lessons learned, right, were drawn with people who engaged with us in this research. And so I'm going to, in some ways, try to take some of what we wrote there that was much more in that informatics context, but I think is broadly applicable. And I'm guessing, this will resonate with those of you listening who've also been doing this work for a long time. So I generally try to talk about this for those who may not have done this work in the past. How do you start? Because I feel like I've encountered so many colleagues, so many collaborators that want to do this work well and ask this question of, well, where do I start? And I'll be curious to talk about this in the discussion part, because I think kind of what other lessons people have learned. But I often talk about starting with educating yourself and your team. And I think of this as a lifelong process, both because even, right, someone like myself who identifies as disabled, and I sometimes say many times over since I live with multiple types of disabilities and chronic health conditions, but just given the heterogeneity of our community, both across disability and across intersecting identities, there are so many experiences to learn about and to incorporate into that lens. And then also just given the evolving experiences. So if we talk about structural ableism and we talked about how structures shift over time, policies shift over time, even those experiences as an individual with a particular, right, constellation of disabilities also evolve over time. So, part of it is education, understanding the historical context of research within the community, broadly speaking, in sub-communities, understanding contemporary debates within the community, right? Understanding different models of disability and those conversations, I think, are all important places to start. And then I think about the second step is building partnerships, building coalitions. So whether we're talking about having advisory boards, talking about having things like community engagement studios where you might bring people together to help think through what do the research questions look like kind of early in the process, or give feedback at several stages of a research process. Making sure, of course, that you have team members who themselves identify as disabled. Back to the right, who's at the table matters, and so having people on the team who are a daily part of the conversation is essential. So all of this gets to the nothing about us without us, right? And I think about this as everything, like I said, from informing the research question all the way through how does the work get disseminated back to the community. So it's not just in the hands of other researchers, but it's in the hands of the community itself. And then we can talk about things like in the research context, certainly how we think about who we're including in our research matters. So how we're thinking about, right, the defining disability. Are we talking about disability identity? Are we talking about functional abilities? Trying to take a broad lens so that we make sure we're engaging as diverse a sample as possible, again, across disability, thinking through all the types of ways we might try to recruit people into our studies, and making sure those are multimodal, that they're audio, they're text-based, they're in plain language. And then certainly the study procedures themselves. So always, to me, this idea of how do you come prepared with alternative approaches to collecting data? The example I like to give here is a study I did several years ago where I wanted to capture people's daily experiences about talking about their health with others in their social network. And there were so many ways to do this, right? And so the idea was to quote unquote journal about daily experiences, but what journaling looked like for each person varied. So for some people, the most accessible way was to do a voice memo and send it over. For others, it was for us to call. So they didn't have to remember to do it, but we had a phone call and they told us what time they wanted us to call. And it was a conversation. For others, it was text messages. For some others, it was writing on a piece of paper and sending that paper by mail, right? There were so many different ways. And right, having that openness to different ways of engaging is really important. And maybe the last point I'll make is kind of as another step is I usually frame this as building foundations for the future, right? So we know just the incredible underrepresentation of disabled people in engineering, in sciences, in the health sciences. And so how do we, as researchers who are in this space, mentor others, other disabled people to be, right, the next engineers, scientists, clinicians. And that's the work of kind of reaching right down through the pipeline and working with students and mentoring them so that, again, there's more of us with seats at the table.
No, that's fantastic. Thank you for helping us better understand a question that I am sure that many of the audience members reflect on which is how to better engage the disability community. And as you mentioned, who is at the table matters. So creating partnerships with the disability community and truly understanding and honoring life experiences are crucial steps to take. Having said this, from a public health perspective, why haven't we done more to include all of these concepts, not only structural ableism, but also on disparities in general or community engagement? Why haven't we done more to include those concepts into our work on health equity and even beyond health equity? Do you have any thoughts on that?
I have a lot of thoughts on that. So let me just say a few things because I think I want to make sure we leave time for Q&A as well. So if we talk about the disability community specifically, I think I mentioned earlier, right, this idea of awareness of the disability community as a community experiencing health disparities is not something that I would say a large majority of the people I've worked with are aware of. That's changing over time. I'm very thankful that that's shifting over time, but it is still, you know, even in 2024, it's still not, I would say, common knowledge. And it's certainly not where many of the discussions start, even though I would say increasingly, certainly the disability community is more explicitly considered in those conversations. And we've mentioned the same idea, right, in terms of looking up the term like structural ableism in PubMed, and the fact that, right, only 5 papers come up with that term is, right, another kind of indication of, you know, just like a lack of awareness or thinking about this as a concept. And, you know, hopefully over time that grows. So that's part of it. I would say that, you know, those of us trained in public health, trained in, right, like health sciences, broadly speaking, the medical model is so ingrained in the way that teaching happens. It's really dismantling, reimagining what that training looks like. I will say we've been doing that here at UVA. It started out very with very baby steps, I would say. It started with one of my physician colleagues giving who is not disabled, but giving one lecture in one class maybe 6 years ago, and then bringing on, right, I remember attending that and having a conversation, and someone I deeply respect and who took a lot of critical feedback from me and some others, like with all the grace, right, that you would, you know, ideally hope for, and said, well, let's do this differently next time, and bringing on patient panel of or a panel of people who are disabled and who are activists, and talking to students, to now at a point where every part of the curriculum is being reimagined to have a disability lens. So, you know, it's been a journey, but, you know, that's work that needs to happen in public health sciences and our clinical sciences and everywhere. So, right, we're given certain training, and we, unless explicitly asked to question that training, right, that's the mental model we approach things with. So I would say that's one part of it. You had a question about, well, you know, why don't we focus on health equity more generally? Why don't we focus on community participation more generally? And I have a lot of different answers to that question, but maybe the one thing I will highlight is I don't think our incentive structures within academia, within research generally align with that approach to doing work. So we are in a model where, right, producing more is good, producing more is incentivized, and doing community engaged work often requires not having that type of production, at least not at the same rate or in the same way. Doing community engaged work well means spending a lot of time with communities where you might not be producing a paper, or you might not be producing a grant if you're doing the trust building work, if you are listening deeply. I have examples of some work in some other spaces where I would say I engaged for 8, 9 years and I don't have a single paper to show for it. We've done incredible work together, and we are now at a point where the community has said, my community partners have said, yeah, we're ready to write about this. But it took that many years to build trust, given the really challenging, right, the really, negative experiences my community partners have had in the past with research, that it took that much time to build trust and to get to a point where we can publish things together off of it, and that feels constructive for them. And so I guess that's all to say, we're those of us who do that work, we're kind of in the system but pushing against the system, and that's not an easy thing. That's not an easy thing to do.
Thank you, Dr. Valdez. This conversation was truly a fantastic reminder that there is still a lot to do to better measure disparities, to educate providers and stakeholders, and to put the disability community and community experts at the center of all of these discussions. So thank you so much for this great discussion. I am truly grateful for the opportunity to have this conversation with you, and I'm grateful for the work you do and these lessons you have shared with us today. So with that, in the final minutes of the session, I want to open it up to our audience Q&A session. We got some questions in the chat, and to start out, there is a question on how can we critically evaluate whose voice and participation are missing from our research and decision-making tapes? How do we find the hidden, the segregated, and excluded?
That's such a great question. And I'm pausing because I don't know the best answer to that question either, because it is a really challenging question. I think the best I can say is that my experience has generally been, even with finding community partners, right? Those who are first willing to engage, have engaged with the system typically in some way, or have taken on leadership roles in the community. Those can be the places I have started in the past. So that's been one approach. And then that those individuals, right, have built trust with others, and they are able to point to other people they have built trust with and say, these are the voices that are not being heard, are not at the table, that we need to reach out to. And then, right, the work is to build trust with those other people. And then those people in turn perhaps are connected to others who are, I think the word was hidden, or, not visible within these conversations. And so for me, it's typically been that type of, I don't know if I would call it a network approach, but right, that you build trust, and those people have trust with others, and those people have trust with others. And that's how we find, right, the people whose voices have been most left out of the conversation, and build trust with them and bring them into the conversation.
No, thank you for your answer. I'm keeping an eye on the time, and we still have around 5 minutes left. So another question that researchers from the audience have is, what advice do you have for researchers, those focusing on disability and those who don't, on how to advance the overarching cause of dismantling ableism in their work?
Yeah, that's a big question. So maybe I would highlight just a couple of things. So one is, I think we've highlighted this multiple times, and so maybe it's just reiterating once again that the first thing, right, whether you're focusing on disability or not focusing on disability, because right, all issues are still disability related issues, because we all live all aspects of life as disabled people, would be to engage with the community. And that engagement with the community, that trust building, that showing up and having the conversations, at least in my experience, has been what leads to the research questions that I would say I would consider myself as a researcher to have been the most meaningful questions I have focused on. But also, more importantly, have been questions that the community has defined or has identified as meaningful. And so I would say that's, a key part of it for me. The second part of it, of course, is this idea of how do you create processes, study procedures, all of that, again, whether you're focused on disability or not focused on disability, to make sure that all disabled people can engage with that research. So, concrete things that I, sometimes talk about as more low-hanging fruit, but show the awareness, the willingness, the ability to engage with the disability community. So, small things like that we did today is providing visual descriptions, having captioning, right? And they can see my small things, but they're not commonplace. I was just at a conference with some of my engineering students last Friday, and I asked them, I told them, you need to have captioning on when you present, you need to give visual descriptions. They had, because they were working with me, even though the work wasn't focused on disability, these were not things they had ever been taught, in terms of doing the presentation. So just they kind of, even though they're low hanging fruit, right, not the norm, asking people what accommodations they need and making sure you meet them. Using plain language, not as, kind of as an addition or an afterthought, but making sure, right, all study documents are in plain language as the default. And back to this idea of course, universal design, that addressing things in this way makes it easier for everyone to engage, right? Not just people who are disabled.
Thank you for the great answer. And with that, I thank everyone for joining us today, and really thanks, Dr. Valdez, for your time and your knowledge and your experiences. So thank you all for being with us today. Thanks to the team behind the scenes running this, and to our captioners, the interpreters that have supported us throughout the entire series. Thank you, Dr. Valdez, and thanks everyone. We hope to see you in future events from the Disability Health Research Center. Take care and goodbye.